Okay, well, welcome everyone. I'm Glenn Galton, Director of the Center for Global Health, and it's my pleasure to, again, welcome everybody to be here today for both live and virtually, I should say, because we obviously have people here and we have many people online in the new world of hybrid conferences. But we're here obviously to honor and to have our annual celebration for the recipient of the Robert Suskind and Leslie Lewinter-Suskind Faculty Global Health Award. And this year's recipient is, of course, Nahreen Ahmed. So just as was mentioned, please be advised that the session is being recorded. And for those online, please ask questions in the chat, and we'll be monitoring those questions. And at the end of the session, we'll, of course, take questions from the audience here, but also from those of you online. I'm looking at the screen like they're right there. For those of you online who want to ask those questions. But just a few words first about Bob and Leslie, the founders of the award. They're simply no greater champions of global health equity. They've spent their lives working seamlessly, and I have to say together, because they do everything together, across the boundary of academic medicine in the US and numerous global settings. They've also recognized the importance of supporting the development of careers in global health. And here at Penn, among many, many ways, this is manifest both in the award we celebrate today, as well as a similar award for our students. Their global focus relies primarily in pediatric health with an eye on nutrition, but after a lifetime of work, their work spans numerous settings and many, many other areas, and their impact is really remarkably broad. Not surprisingly, as Bob will mention, and I think it's Bob, not Leslie, in a second, they're in Argentina. And so they've taped a welcome message for all of us. And so Lejo, we can play that now.
I would like to start this off by saying and congratulating Glenn Galton and Megan Doherty for the wonderful job that they have done in building global health at the University of Pennsylvania. Nahreen, this is Bob Suskind speaking with you from Buenos Aires, Argentina. And we want to congratulate you on all of the accomplishments you've had in the short career that you've had in global health. There is no question that with your energy, with your foresight, with your enthusiasm and creativity, that you are more than deserving of the award in global health for faculty at the University of Pennsylvania. And so my wife and I, Leslie, and I are so happy to congratulate you on this accomplishment. Maybe you want to say something?
Yes, as I said before, I think that if we really are going to succeed, we have to clone you and put you all over the world. But since you are one, and a very dynamic one, we are so grateful. This world has to be so grateful for your intent and for your accomplishments. And I thank you, and I thank you for the future as well.
You know, Nahreen, it's really amazing what has happened at the University of Pennsylvania since I was a medical student there some almost 60 years ago. When there was no global health. It has been amazing in terms of what the university has done in the field of global health. And one of the real accomplishments was having recruited you as a member of the faculty, as a junior member of the faculty. And what you've accomplished in terms of your activities, whether it was in Ukraine, in Bangladesh, in Ethiopia, in Sierra Leone, or so many other places where you have made a difference as a clinician in critical care, as an expert in the use of ultrasound at the bedside, and the path that you're leading to really make a difference in the lives of physicians around the world, and more importantly, the patients that they're caring for. The thing that is so nice is that you have youth on your side, and you will have, I'm sure, at least another 40 or 50 or 60 years in the field of global health. And you will be able to make a continued contribution based on your experience based on the support that you have gotten from your family, from the university that you've attended, and the training that you've had, and the orientation that you've had in terms of making a difference as far as the lives of adults and children around the world. And not only are you an accomplished physician in terms of critical care and the use of ultrasound at the bedside, but you're a physician who cares for making and wanting to make a difference in the lives of the underserved in a global way. We are so happy. We were so happy to meet you the other day virtually, and we look forward to seeing you when we come back to Penn for our 60th reunion next spring. But you want to say anything else on it?
Yes, I just want to say this, and I know I'm reiterative, ask my kids, but I say this often. We are one species on one incredible planet, and we have got to make sure that every person on this planet is cared for in all ways, health and education. And we have to clone, as I said, because you can make a pivotal difference in the future of this planet. So thank you so much for what you do and what you're going to do.
And I want to thank all of the members of the global health team for what they have done in terms of making a difference in the world. And I am so proud of the accomplishments that you've made and the role that you've played in making a difference in people's lives.
Well, they're terrific, as you've seen. So thank you so much, Leslie and Bob, for your kind words. I always pay them to say something nice about Megan and me at the beginning. I also want to give a special thanks to Casa Dargay for being with us today. Casa was last year's recipient. Unfortunately, that event was entirely virtual, so he and I were together. But Casa, if you just stand up and let's give Casa a round of applause. So thanks again. So now on to Nahreen. Dr. Ahmed is a Philly region homie, as we say, and after her time at Drexel Med and then residency in an MPH at the University of Illinois Chicago Medical School, she did her fellowship in pulmonary medicine and critical care at NYU. And it was here that she really formally launched her initial global work in Bangladesh, and I know we'll hear something about that. Unfortunately, Nahreen returned to us as a member of the faculty in 2017 in the pulmonary division, pulmonary critical care division. But frankly, Nahreen is an atypical global health colleague. Most of us who work in the global health space remain super, if not hyper-focused on pairing our scholarship here at Penn directly to our global efforts. And there are indeed times when Nahreen's work takes on the flavor of a classical academic pursuit. But just as often, Nahreen recognizes the importance of directing her efforts to simply and practically solving real-world problems, be they academic or not, and thereby addressing health equity at the ground level. That might be in Philly, or in Bangladesh, or in the Navajo Nation, or Yemen, or Ethiopia, or Kenya, or Colombia, all different places she's been, Ukraine, et cetera. We'll hear about this. Her partners are whoever is needed. And her approach is whatever it takes to get the job done. It's unusual, and it's at times challenging to manage in an academic setting, as she knows, and Jason and I know. But in the true tradition of Leslie and Bob, it's both impactful and inspiring. Nahreen?
Ooh, I'm a little overwhelmed. It's a lot. So first and foremost, thank you. Just make sure I can click on this. First and foremost, I want to take a moment to say some thank yous. A huge thank you to Bob and Lewinter-Suskind, who made this opportunity possible. Their life's work is an inspiration, and I'm honored to have been considered for this award. Thank you to Jason Christie and Glenn Galton for their constant guidance and support that has allowed me to elbow into a unique and niche career space, a dream I've had for nearly 2 decades that's finally started to come to fruition. To my colleagues who have swapped shifts with me to make it work so that I could leave the country on a moment's notice sometimes, I thank you heartily because I know that's not always easy. To my co-fellows, many of whom I think are here virtually, you created the space for me to launch this career. During fellowship, you showed me what collegiality looks like in covering clinics so that I could jumpstart my first program in Bangladesh, despite a lot of people saying, no, that's not gonna work. And lastly, and probably most importantly, a major thank you to my family. This includes a large number of people, friends and relatives who've cheered me on from near and far, who've watered my plants and checked in on my house, or welcomed me home after a difficult training trip. All of these people have shown me that these achievements and accomplishments do not happen in a vacuum, but are shared and require a village, a lesson on how making an impact in this life and in this world requires a team effort. It can never be done alone. On that note, I'd like to take a few minutes to reflect on my career and experiences. I'll start by saying that as a junior faculty member with only 5 years of an attending career under my belt, I felt a twinge of imposter syndrome coming into today. When I sat down to reflect on my career, however, I realized it started as a medical student with carefully crafted decisions that have led to today. So I'll start with the beginning and give you a brief overview on how it started and how it's going, as the kids say these days. In 2010, I embarked on the first step of my journey, going to Bangladesh as a fourth-year medical student for a month-long rotation in the pediatric surgery department at Dhaka Medical University Hospital. Though I knew a surgeon's life was not for me, I was hopeful to soak up as much of the experience as possible so I could understand the role that I could play as I grew into my career. It was less the pediatric surgery rotation that caught my eye, but the additional experiences. Seeing how NGOs work in rural areas, sitting in on community outreach sessions, such as the one you see here, and seeing how the focus was on educating and empowering women in this particular session, and how that led to a reduction in neonatal and maternal mortality during birth. What I took from that experience was that a focus on education was a key component to whatever I decided to pursue in the future. By the time I started fellowship, I had fallen in love with critical care, but realized that it was a subspecialty that favored resource-rich countries and institutions. Nevertheless, I wanted desperately to seek out a way to match my love of critical care and my need to create innovative solutions in the world to reduce health inequity. This is when the narrative flipped. In learning about the global approach to resource-limited countries, I started to see a pattern of colonial intervention, organizations bringing their own opinion on what was needed rather than asking the simple question of how can we support you? After administering an in-depth needs assessment in an ICU in Bangladesh, it was revealed that the diagnostic imaging of portable X-ray was not always available. And it was then that I launched my first training program in point-of-care ultrasound, a training program that created local trainers. As you see here, I'm training them on the left in the many uses of ultrasound in the ICU. This training program then created these local trainers who within 2 years had taken the program, which was a pilot program, and adopted it into their academic curriculum. When I showed up in Dhaka a few years later, it was this image to the right that I came into, which was a trainee showing me cases of how using the ultrasound that I helped crowdsource and how it had saved lives, showing several images in several cases without even knowing who I was and what part I played in the program, which was actually awesome. It was at this point I realized this path is possible and it's worthwhile. I wondered how else I could utilize this concept to spread basic training programs in areas where access to health was incredibly limited. This led me to the largest refugee camp in the world, in Bangladesh, where nearly 700,000 Rohingya refugees had fled from Myanmar. I joined a small and new nonprofit called Med Global, who had opened a clinic in the camps. And instead of seeing patients, I pitched an idea. I pitched the idea of working with the community health volunteers, all seen here in this image, all who are Rohingya, and pitched the idea of addressing common medical issues that were seen in the camps, things like asthma and diarrheal disease, and to talk about how to prevent or manage signs and symptoms, as well as when to seek medical attention. Seeing the impact of conflict changed me that year. That was when I realized that displaced persons and populations impacted by war are those who are most forgotten over time, and also those who have the least amount of access to healthcare. This led me to war-torn Yemen to continue training in point-of-care ultrasound in an ICU that sees everything from trauma due to IEDs to sepsis. The physicians there felt abandoned. They felt like the world had forgotten about them, and yet they continued to operate under dismal conditions with minimal resources and leftover donations from years past that were now defunct. Empowering them with new skills within the resources that they had, and sitting with them to understand how we could help fill the gaps in a sustainable manner, that is when I found my stride. And so with Med Global, I went onward to more conflict zones to create and build programs that can help improve access to care, by supporting clinicians and community healthcare workers. This led me to the border of Colombia and Venezuela, which you see here, where I stood at the border and witnessed hundreds of Venezuelans crossing over treacherous land to get to safety in Colombia. Many of the displaced persons that we interviewed were women. They were pregnant and were planning to walk across South America to other countries where they maybe had family or friends that were awaiting them. They had received no prenatal care, no vaccinations, no pregnancy ultrasounds, any kind of comprehensive care at all. Our organization now is providing those things to as many patients as we are able right at the border. It was here that I learned that despite my expertise in critical care, I can continue to build programs and impact outside of that. As many of you are aware, COVID created a pretty big hiccup in our lives. It leveled my ability to travel internationally, which of course was depressing, but more so, what was depressing was I thought the work was going to end there. It opened my eyes, though, to health inequity in our own country. When I traveled to Gallup, New Mexico, to Navajo Nation, where I worked with a valiant group of clinicians, seen here on the right, to provide care in a motel-turned-isolation center, which you see on the left. A relationship that is ongoing, as the real impact was actually aiding the internists that you see here on the right with their management of critically ill patients. These are incredibly hardworking primary care physicians who deal with their outpatients and the inpatients and the ICU patients all at the same time. And the biggest impact that came from this trip was just starting a simple WhatsApp group chat with willing ICU doctors and pulmonologists from across the US who basically were just consulting on cases and providing support. And that has led to many, many lives saved within that ICU just by that simple act. It was here that I learned to delegate, create a group around me with a shared interest so that these projects can grow based on need. With COVID continuing to limit our travel as an organization, I started to dig deeper into the concept of decolonizing our approach to global health. How can we improve our ability to empower clinicians and provide support from afar? This led to widespread sharing of resources and improving internet access in sites where it was limited. In this particular slide, the content being taught was contributed by our very own Dr. Cameron Bastion here at Penn. The lesson I learned in this was that anyone can contribute to furthering the mission of reducing health inequity, no matter where in the world they're located and no matter what their background is. This was in Gaza. March 2022 heralded in what is now one of the biggest conflicts that we've seen, the war in Ukraine. When asked, how can we support you, to the physicians and frontline medics in Ukraine, the answer was, we need ultrasound in the field, we need help with trauma surgery skills. Under Med Global, I helped lead the development of our surgical skills lab. Yes, I am not a surgeon, but was able to recruit heavily within the surgical field, and we are led by a brilliant Ukrainian and American group of surgeons, as well as the ultrasound course that we implemented for frontline doctors. This program brought me to Lviv, to Ternopil, and then most recently to Kyiv, to train ICU doctors at hospitals receiving mass casualties and trauma, and to train frontline medics to identify life-threatening processes needing immediate attention. These were frontline medics that were being sent to the frontline literally days after undergoing these trainings. Within days of our first training mission, we had heard about medics identifying internal bleeding, lung collapse, which were then properly managed, thereby saving lives. This situation reminded me of something my late grandmother had said to me. You have something to offer the world. You are lucky to have received the education that you have, and so you have the responsibility to do something meaningful with it. While I'm immensely proud of the projects that I've had the privilege to be a part of, I'm even more in awe of the additional impact of being physically in the field, which are best explained by two stories. In this picture, you may notice that I'm the only female in this group of doctors in Yemen. It has been a challenge to navigate the global health field, where most of the medical leads in other countries are men. After this picture was taken, a female nurse approached me in tears and said, "Thank you for showing us that women too can lead." I was so touched by this moment. It wasn't the work that we did, rather the representation as a female lead of the project that made the biggest impact, I believe. It was that moment that has led to a unique trainee recruitment in all of our countries that we work in that attempts to address the gender bias in the field of medicine. The second story highlights what I feel to probably be the most important lesson of all, giving a voice to those who may be silenced. This story starts with a Rohingya woman pictured here. She obviously gave permission for this picture to be shared worldwide. She previously was wearing a face covering for religious reasons, but she told me the story of how she traveled from Myanmar across the border with a family of 9. She arrived in Bangladesh, however, with a family of 5. Her husband and 3 children were murdered in front of her. She spoke of the atrocities committed to those around her. And then I asked her, "Can I share your story?" She, in that moment, removed her face covering and she said, "Let the world see me. Let the world hear my story." In Yemen, it was a woman who said, "Tell the world we are still here." And in Ukraine, it was a young doctor asking me not to forget him, and not to forget them, and to make sure that the world does not forget. Each individual wanted more than the training I came to offer. They wanted their voice to be amplified. They wanted to be heard. This is a reminder of the privilege we share as clinicians and as humans to be a part of the human condition at a point when people are their most vulnerable, wherein we can provide hope or palliation, or most importantly, advocate someone's voice. And when given the opportunity to have a platform to stand on where the world will listen to what you have to say, I believe it is our responsibility to be the voice of those who are silenced. At the end of the day, it is our collective voice that will help to move the world forward to a better place where health inequity and injustice are lessened. I thank you very much for being here today, and I truly appreciate all the support. Thank you.
We'll open it up for questions from the group. I think it's a small group, relatively small
Sure.
group. So you can just ask Nahreen directly. Maybe I'll kick it off if it's okay. Maybe I should be on mic. So yeah, so that the recording hears. Yeah. So Nahreen, you know, typically when people work in the global space, they're overlapping either with academic institutions or ministries of health. And, you know, the challenges, at least the ones that I frequently see, are barriers. You know, we can get things done, but the sustainability of what we've done and the ability to keep things going. So you know, your projects are typically working more directly with the on-the-ground folks who are running the local plans. Have you found that that's you know, maybe a more positive experience than some of the difficulties we've encountered working at a higher level within government ministries, or do you face those same challenges in those settings as well?
Yeah, so I guess I left out the ugly part, which is we still deal with the ministries. It's the way we get into the countries, the way we get approval, and it starts with the conversations with the ministries of health. And so every country that we work in requires it. But I will say, once that is usually out of the way and the proper paperwork is done, it's the local communities, the local NGOs, and the local hospitals where we find the most impact can happen and the conversations are truly productive.
Yeah, I like that. You got to talk to the ministries to get it started.
You got to shake all the
And then
hands
maybe
first.
You
Yeah.
can get them out of the way. Yeah.
Nahreen, congratulations. Tell us about point of care ultrasound and whether it is truly a powerful tool or whether it helps to open the door to important discussions, and then how you've used it to be able to make for even better group learning. So it seems to me like you have brilliantly leveraged that skill set to open an even bigger opportunity. And I wanted to kind of figure out where the ultrasound fits in within that discussion.
Yeah, so I think when I first started out, I don't think I really understood the impact of ultrasound. In all honesty, I think I may have been one of the ones who wanted to leave early from our POCUS boot camp in fellowship. My co-fellows can keep me honest if they're still on here, but I'm not sure I really bought into it at that point. And over time, using it clinically myself, so point of care ultrasound, for those who aren't familiar, it's when the diagnostician or the clinician who's at the bedside can use the ultrasound to identify something, act on it, integrate it into their clinical decision-making immediately. Takes out some of the other steps wherein we might have to call somebody else to come to the bedside. It's more of a screening tool, to be honest. We still need the formal cardiac ultrasounds and things like that, but it gives us more information. And we all know as clinicians, more information is better for clinical decision-making. And so as I started to learn that, it really made sense to me that it was a powerful tool. However, in the context of global health, I saw an opportunity for it, but I also felt that it would be wrong of me to say, here, take this machine. Something that's done in global health quite a bit. I've been to a lot of places where people donate ventilators and they're sitting in a closet somewhere because no one knows how to use it, or the power is out 80% of the time. And so at the time, it was just it opened up a conversation that this could be impactful. Let's talk about it. And with the clinicians in Bangladesh, The one thing I remember hearing was that the X-ray machine, the portable X-ray machine, was broken many times, most of the time, in fact. And there were many reasons why it couldn't immediately be fixed. And so in asking deeper questions about what could be the most impactful thing that we could offer and help in support of their clinical decision-making, point of care ultrasound kind of evolved into that space. Now in global health, it's being used in a similar manner to kind of fill the gap of the missing diagnostic imaging that's not readily available. And so to answer your first question, I think that it is truly a powerful tool for many reasons. The maintenance of a machine it's much easier to maintain that versus the portable X-ray machines that you see and all the different things that come into using those, including a tech. And so I think that the concept of giving the clinicians more power to make informed decisions, especially in places where diagnostic imaging is truly limited, I think that's the key in the power of it. I think in a resource-rich hospital, yeah, I think sometimes it can be seen as sort of something that's not adding impact. However, I know that many of us in the room can speak to things that we've found on ultrasound just in surveying a patient who came in shock that we may not have been able to discover by just our clinical exam. And so I think in recognizing that, I think it's truly a powerful tool. In general, though, it has also, I think, revolutionized how we're teaching. It has shown us that practical hands-on skills and skills building is truly important in a lot of these parts of the world. That when we would go and do these point of care ultrasound training sessions, there would also be significant discussion of clinical management and just hands-on skills. That's something that's missing in a lot of global settings, and that comes down to limitation of manpower. You have, attending a limited number of attending physicians and a huge number of trainees, and you just can't give them that one-on-one or even 5-on-1 training ratio. And so I think this also has revolutionized how we're bringing education and hands-on skills building to the field. You may have had one other question in there. Was that?
No, it was perfect. You're thinking exactly, you're saying what I wondered, which is that A, it brings you back to the bedside, it fosters feedback, group discussion, and it opens a door to a educational dialogue. And I just think you've done it so well.
I appreciate that. Thank you.
Such a difference. So, yeah.
Thank you very much. It's unbelievable. It's so impressive. As the Suskind mentioned, in such a short time, so much. It's just unbelievable. Congratulations.
Thank you.
Two things. One, are you carrying out these undertakings under an organizational umbrella? And how is that construct? And secondly, what are the criteria for selecting a site?
Yeah,
where
these
you go?
great questions. So the first question, all of these programs are under an organization called Med Global. It's a nonprofit that works mostly in conflict zones and with displaced persons. And so all of these projects sort of fall under that. The beauty of that is that there's a built-in team that aids in the sustainability and the follow-up. And so we have a field team that coordinates all of the activities on the ground. We have a headquarters team that coordinates the follow-up. And really my role is purely as the clinical educator, which is great. And program development, so really I get to purely play that role while the team kind of does what they do to keep the programs running. The second thing, how do we choose the sites? To be honest, initially the first site for Med Global was the Rohingya refugee camp. It was fueled by the president of the organization, who is a Syrian refugee himself, who fled decades before, who lives in Chicago, and he saw this as a way to give back in a scenario that reminded him much of his own. And so that's where we started, and the organization quickly developed into an organization that responds to areas where there may be displaced persons or where there is conflict affecting the population and limiting the healthcare that's available. So that intertwined with, do we have the capacity to respond? We're a small organization, but we have a massive volunteer population. And so because of that, we've had the capacity to respond rather frequently in many of our sites. Right now, I can tell you we have a team in Ukraine, we have a team in Colombia, and we have a team in Bangladesh simultaneously. And so that just goes to show that these programs can happen simultaneously. We have a team that's big enough to do that. And we really rely on our volunteers, who are much like myself, just kind of clinicians. That's what they call their day job, and this is sort of the thing they're doing on the side, which for many of us has become a part of our career. So that's kind of how the two go hand in hand.
And by the way, So that's what I was getting to in my comments about some of the challenges, is how, because she's doing incredible work, but how we manage that in a classical academic setting is a challenge. And frankly, one we've got to figure out, because we don't want to lose this effort from the academic system as well. So that's something for all of us to think about. And Jason and I are working with Nahreen, and I want to say, I hope you saw, did you get my email?
I did get your email, yeah,
Okay.
thank you.
So we're working with Nahreen. We haven't finished it yet, but we're working with Nahreen to help us effectively organize, for example, global health within the division. And I would phrase it, over time as respiratory medicine more broadly in our community, and how we can think of creating and identifying strategic need areas that others can participate in, because not everyone's going to have the time or the personal situations to, or the guts, basically, to travel like Nahreen does to all of these sometimes dangerous and difficult places. But we want to bring that forward as an institutional effort, and we have to be able to think creatively about, I'm going to say, sort of non-traditional academic careers, and often global health fits in that space.
Yes, thank you very much, and congratulations again, Nahreen.
Thank you, Leah.
Does anyone else have a question? I'm sorry.
Thank you. Congratulations. You're doing an incredible job.
Thank you.
It's just about how do you manage the sustainability of your initiative? This is coming from my experience. I worked in Botswana for 7 years, and we, with our UPenn oncologists, we started a breast multidisciplinary tumor board. I ran actually rapid on-site evaluation of these things. But after I left and I came, it's actually literally stopped. I was just wondering, how do you keep motivating them, and how do you make sure that your initiatives are sustainable? That's what I want to know. Thank you.
Thank you for your question, and for your work in Botswana. That's amazing what you were able to accomplish, and this is probably one of the most challenging areas, and is absolutely, before an initiative starts, that question of how we will sustain it is the first question that has to be answered before we initiate any program. Typically, that starts with buy-in and a conversation with the field teams to say, how can we support you? It's being driven by their request, and because of that, there is a lot of initiative and motivation to keep things going. And then it's the hard work of finding somebody to champion it on the ground. Much like any program we start anywhere, even when we bring ultrasound to other places in the US, the one thing they always tell you is you need somebody to champion the program. You need somebody that's as motivated as you are to do it. And that's really the most challenging part. And usually that comes with identifying at least 5 people in every site. It dwindles down to about 2 that end up being the champion, and then maybe 1 over time. And especially given in many of these areas, folks get trained in things and then they go somewhere else where they can make more money, which is understandable because they work in a hard place. It's an austere environment. They want to provide for their family. That's their priority. And so while we understand that, the conversation is always, we encourage you to do what's right for you, but we also need to figure out who takes over after you. And so keeping that conversation open, ensuring that they're supported, and making sure that that's a frequent conversation is really important. And the other part of that is providing some kind of continuing medical education. That has been probably the biggest plus side in creating a pathway to sustainability, because they know that there's always ongoing educational opportunities from us on the other side. We have focused primarily on the education, and because of that and how enriched of an environment that has kept people motivated. We really shy away from doing direct clinical care. It kind of happens indirectly, obviously, when we're there, but the educational aspect and building that's probably been the biggest thing on our side to provide sustainability, but it's very hard. And what you didn't hear are the programs that didn't make it, right? You're only going to hear about the successes today, but it's important to mention that there have been failures, and much of that is due to what you mentioned, the sustainability.
Thank you, Nahreen. We do have a question here in the chat. What advice would you give to young trainees or newly faculty members here at Penn in terms of professional development and the steps that you took to get involved in the global health work that you're doing currently?
Yeah, that's a great question. To advice for trainees, I would say, find mentorship where you can. Do not limit yourself to the academic university that you're in, because sometimes those people fall outside of where you are. All of my mentors, I had one mentor at NYU, and most of them were actually outside of NYU, but connected from my one mentor at NYU. So I would say, one, network outside of your internal network. And two, don't take no for an answer. I got a lot of no's in the beginning, mostly no's, and even now that continues. But if there's a vision that you have with what you want your career to look like, be flexible, but also be persistent. Keep knocking on the doors, because at some point, someone who's willing to support you will answer. And I think that truly is what happened with me, and continues to happen, where, there's been a lot of success, but there's also been a lot of doors slammed in my face of people saying, I don't want to support that. There's no money in that. So what is it that you're going to bring to the table if you can't bring money into this conversation? And that's tough. But I think the work is incredibly fulfilling. Only work for free for a short period of time and then figure out a way to make money, at least to support your salary, because it's noble work, but if we burn out, then the work ends. So that's an important piece of advice as well. And then, reach out for anybody that's looking for, I would love to share what went well and what didn't. I would not want anybody to go through the same, any mistakes that I had made. I would love to be able to help people learn from that. And I think that's the best I can offer.
Thank you.
Do we have other questions? I have one final one. So that you had that great picture of you with all the guys, and you mentioned the nurses. So what about nurses in the global setting? I mean, one of the things that's the transitions that have actually, I think in a very positive way happened in our country, with nurses assuming greater and greater responsibility through different educational pathways. That's not a traditional phenomena in many, many parts of the world. But have you had experience training nurses in the ultrasound techniques, and whether that's embraced, and whether you face different hurdles in that sector versus the physicians?
Yeah, so we actually are launching several nurse training programs. Midwives especially. It kind of started with midwives because obstetric ultrasound is such a huge need, with the maternal fetal mortality rate still being as high as it is worldwide. And so that is really where we edged in to say, you don't have to be a physician. There are things that we can train easily enough, which can be very high impact. So that's actually going pretty well. But the buy-in has to come from the top. So the physicians have to be okay with that. It's a very interesting dynamic, but it is something that we're working towards a little bit more, because I think it's important, and even just nurse training in general is something that is often overlooked in the global setting, but it is very much goes hand in hand with training physicians. You can't do one without the other, to be honest.
Okay, I think we have no other questions. So we have a very heavy award. I mean, it's really heavy to present to Nahreen. And congratulations again.
Thank you so much.
And we'll do some photo ops.